of course, age, fitness condition, hormones, and autonomous intervention. You can get nervous or fear or shocked. And then here you have the heart rates, again, the fitness level, gender, contractility, duration, and so on. Now, here is interesting. Stroke volume is equal to end diastolic volume and end systolic volume. End diastolic volume this is related to how much you get back through superior and inferior vena cava. Because, right, if you have a problem with the veins, you're not walking, you're not jogging, you're alive, then the veins cannot manage. They don't get that help from the muscles to push it up. So you will not have enough end diastolic volume. So of course, your stroke volume will be reduced. So these are the factors you should take a close look. Yeah, there was this. There you have the formula. Here, you see? It is height. I was totally wrong that the formula was. Body surface area is height in centimeter into weight in kilo divided by, not here, divided by 300. So height and weight and height. Yeah, you have the formula there. So body surface area calculation is height in centimeter into weight in kilo divided by 3,600 and then the root. It's empirically done. And that is how cardiac index is very interesting and important, actually, more relevant parameter than cardiac output alone. Yeah. Here you see a laminar flow with maximum velocity in the center and gradually reduces to zero as it comes to the wall, vessel wall. And determinants of resistance is blood viscosity, is proportional to resistance, length, and here is the relationship. So there, the systemic vascular resistance is determined by these parameters, by these conditions. Parameters of interest is, of course, oxygen delivery, oxygen consumption. Oxygen delivery, how much air we get in during a certain time, then we know how much oxygen we take, right? And then during our expiration, if we analyze during a certain time how much oxygen we deliver, we exhale, then the difference is how much we have consumed. That we will look more closely when we look at Fick's law. And then comes blood pressure and central venous blood pressure, central venous pressure. So again, the pressure difference between this left ventricle and right atrium, that is the driving force to the flow, to the systemic flow. And as you see, it's roughly mean arterial pressure is about 93 for about normal 93, and here it is 0. Some literature might even give you +2. Guyton might have given -2 millimeter mercury. So here is the relationship between blood flow, velocity, and cross-sectional area. Remember, equation of continuity. The same amount that flows through the aorta with cross-sectional area of 3 to 5 centimeters square gives you a velocity of 40 centimeters per second. the same amount is flowing through capillaries, millions of them, and then the cross-sectional area is now 4 to 6,000 square centimeters. And then the flow velocity from 40 centimeter is reduced to 0.03 centimeter. Why? Is it good to have so low velocity? It is essential, because only then the exchange takes place. It has to go slowly so that it has enough time for delivery and collection, delivery of nutrients, collection of garbage, waste products. And then, of course, vena cava, inferior and superior, have a larger cross-sectional area and lower velocity compared to aorta. These are the parameters we measure. And calculate. And we have today, thanks to echocardio systems, we don't need to go every time into the aorta or into the vena cava. We can fairly accurately calculate the dimension, disorder of the valves, closing of the valves, leakage, flow, ligament. How about determining capillary blood flow? How can we reach and understand the capillary blood flow? When would that be interesting to understand the capillary blood flow? How can you measure blood flow in capillaries with diameters 5 to 10 micrometer? Flow velocity so low. Hello? Yeah. How would that be possible to measure? Yeah, actually it's possible. It's possible, and it's important sometimes to know. For example, you got burned, and you got some treatment, or you got your replacement of skin, and you want to see how it is working, whether the capillaries are regenerated. Sometimes when you have some blockage, then new vessels are created. So has there been any new vessels? Are the vessels flowing? Are they in function? So you can use laser Doppler flowmetry to determine flow in a singular capillary, for example, to see the healing process, to see the effectiveness of treatment, to see if the grafting has functioned. So you take skin from some other places and graft in the burn injured area and see the treatment efficiency. This is how our heart looked like before we were born. So this is how our heart functioned for about 9 months. And fetal circulation is important to understand. And it's very interesting to also understand and appreciate the physiology, how it works. I don't know if you can see the numbers here. They're very interesting. This is the placenta. So this is where you get your blood. The fetus gets blood from the mother. And the blue, if you follow the blue line, the umbilical cord vein, the vein is, in this case, the vein is carrying blood that is more rich in oxygen. There is another vein which does that. What is that? Pulmonary vein, carrying blood from the lungs to the left atrium. That is called vein because it is coming to the heart, right? So pulmonary vein is carrying oxygen-rich blood. And this is the other one, umbilical vein, carrying blood from the mother, which has concentration of about 80 millimeter mercury per square pressure. That is related to concentration, right? Now look, that blood, of course, much of it goes to the, some of it goes to the liver, but then that number 80 becomes 67 because it then combines with inferior vena cava and it is now diluted to from 80 to 67. And that comes to the right atrium. And from here, you see, there is a hole called foramen ovale that is normally closed after birth. As soon as you start screaming, you create a pressure and then hole closes. In most cases, it takes about 2-3 months to fully tighten. Some cases it doesn't, then you need to have surgical intervention. And not all of it goes to through the foramen ovale to the right, to the left heart. Some of it comes to the right ventricle. And then, if you look what happens here, there is another interesting anatomical difference: ductus arteriosus. If you look here, this also closes after birth. So these two holes, foramen ovale is a hole, and ductus arteriosus is a connection. So what happens is, you see, this ductus arteriosus has a concentration of oxygen 52. So umbilical cord had 80, that reduced to 67. Now it is 50. Now it is 52. But what I want to bring to your notice is interesting is the aorta. If you see the aorta here, which is carrying blood to the brain, and mostly fundamentally interesting to brain, has 62, because this ductus arteriosus meets with aorta at the descending range. So the brain doesn't get 52, it gets 62. So brain gets more oxygen-rich blood than your lower part of the body, because brain gets blood from the ventricle, because about through the foramen ovale, the blood comes, and then from the right ventricle, it goes to the pulmonary artery. About 10% goes to the lungs, because the lungs is not functioning. It has a very high resistance. So 90% of the blood goes to ductus arteriosus. But that percentage which goes to the lung and comes back and is pumped through the aorta, that is the one that goes to the brain. So it's interesting that how beautifully it is organized, that brain is developing more rapidly, needs more oxygen, and it gets ensured that it gets better quality blood than the remaining organs. So take a close look and follow the pattern, and you will appreciate the nature, or whoever, I don't know. And here,
attitude. I am confident
here
that
we
it'll
can get often
better
problems
than the auto.
with
Hopefully
the Karolinska Hospital has a unit which is working mostly with the valves disorders, congenital, that is after birth disorders. For example, we have 4 valves here, you see. One, the pulmonary, here we have the valve between the ventricle and atrium and ventricle. So the left and right, they are the big ones. And then you have 2 more valves here, pulmonary valve and aortic valve. What happens is, you see, the blood from the right ventricle has to go to the lungs. And of course, again, the pressure difference between right ventricle and pulmonary artery will ensure the flow. But if you have a problem with the opening and closure of the valves, then there will be disturbances in the flow. And if the blood cannot reach the lungs adequately, then it is not properly perfused. It's not oxygen rich. So you get poor quality of blood to the heart. So there, if there is a problem, it doesn't fully open. That happens after birth. So in many cases, about 10 in 1,000. Then you need to go in with catheter and try to open it as far as possible to make sure that you have the right pressure difference. And if you cannot, then of course you have to open sometimes. Sometimes you replace these valves because sometimes these valves, outer valves, must be more strong. This valve, you could have lived without because it would anyway pump. But what about this one? Much stronger. It has to work through. It has to withstand a larger amount of force difference. Yeah, outer valve. So there could be also stenosis, not fully opening, or a leakage, or a blockage down the outer, causing change in the resistance. Change in the resistance means increase the load of the heart, and that ultimately causes some disorders because of the high pressure difference. How do you determine the disorder of the valve? That is what the stethoscope is. Very simple device, first medical device, and skilled clinicians can hear the sound and can understand if they're working in phase synchronously, if they're fully opening, if there is a closing, if there is any leakage, they can understand the murmuring and gurgling sounds. And of course, those who have access to million coronary device, echocardio, then they can also see all the images and see the leakage and so on. So here we have cardiac output and cardiac index, preload. The preload is the amount of ventricular stretch at the end of the diastole, and afterload is the amount of resistance the heart must overcome to open the aortic valve, push blood volume out into the system of circulation. So both cardiac output and index are important parameters. This is familiar to you from earlier lectures, maybe 2 years ago. This is very, very important for you to analyze. And you see excellent coordination between the electrical activity that we will talk next time. So when the heart muscles are depolarized, the cells are activated, then this P wave, the depolarization of the atrium, QRS complex, Q is the depolarization of the right ventricle, R is the left, S is R is the myocardium, the muscles, and S is the ventricle. So this is called complex because it is combined, it is contribution of right ventricle, the myocardium, the muscle in the center, and the left ventricle, and then the relaxation and repolarization. So this electrical activity causes change in the pressure in the ventricle, in the atrium, in the ventricle. And that change in the pressure causes opening of the valves and flow of the blood. So, and flow of the blood means change in the volume. So this electrical and mechanical activity together with the acoustic activity, which is the closure of the valves, give us a complete understanding about the function of the heart. So take a close look and see how they are related to one another, how one causes changes in the other. You may get questions like this in the exam where you have to draw and show how they are related to each other. And this is also, you do the measurements and get this left, for example, here, left ventricular pressure and volume change. You see, what happens is, you see, Here, the volume changes, but pressure doesn't change much. And then suddenly you have no change in volume, but huge change in the pressure. When the mitral valve closes, suddenly the pressure increases as much as to open the outer valve. As the outer valve opens, the blood flow goes out to the outer, the volume decreases, pressure increases with maximum air, and then it goes down. And later you see the valve, outer valve closes, and the volume doesn't change, but pressure reduces. So this volume, left ventricular pressure volume relationship is also interesting, because that will also change in pathogenic conditions. And there we get the systolic pressure and diastolic pressure. And the difference between systolic and diastolic, that is why we call it the pulse pressure. So we have systolic pressure, the maximum when the outer valve closes, diastolic pressure when the outer valve opens, and the difference is called pulse pressure. And there is another one called mean arterial pressure, which is the integration of these and average of that, which is roughly equal to diastolic plus 1/3 of pulse pressure. So if diastolic is 70, systolic is 120, or say 130, so 70 and 130, that will be 60 pulse pressure. So 70 plus 1/3 of 60 is 20. So 90 would be your mean arterial pressure. Yep, and there we have the relationship between end diastolic volume, end systolic volume, end diastolic volume, and then we see the stroke volume. So this graph can help us to understand the relationship between systolic pressure, diastolic pressure, and stroke volume. How this end diastolic volume and end systole can change different characteristics of the tissue. Here you see, this is how aging has an effect, male or female has an effect, and genetical factors have an effect. So, what is blood pressure? What factors affect blood pressure? And how do you get this relationship to different pressures and different laws that govern or help us to understand? And this is also very important. What are the causes of diseases of the blood vessels? Atherosclerosis, hypertension, smoking, high lipid levels in blood, obesity, familial history, diabetes, life cycle, and alcohol. All right. What is interesting here, you see the oscillatory pattern disappears as blood flows into the arterioles and totally disappears in the capillaries. And what does systolic pressure tell us? What does diastolic pressure tell us? What information do we get from that? Systolic pressure, of course, is telling us about a lot of things, like how strongly our left ventricle muscles can pump. Number two, how strongly it can overcome the resistance to the aorta, how compliant the muscles are. Diastolic pressure is telling us about the qualities, mostly about the qualities of the aorta valves, as well as the quality of the aorta vessel itself, aorta blood vessel itself, its compliance. and if it is affected by the atherosclerosis, accumulation of fats or lipids. This pattern you might see, you will see in the lab also when you are recording your pressure. This is called dicrotic notch. You have it in the, you won't probably see in the very elderly people, but younger people you will see it very clearly. Because this is, happens when, as soon as the aorta valve closes and blood wants to flow back, but valve is closed, so it goes back again. So that is what the interaction of, due to, as soon as the aorta contracts, blood wants to go, it should move forward through the aorta, descending aorta, but it also tries to escape to ventricle. But then it finds the ventricle closed, so it goes back again. So that kick from the aorta valve is giving rise to dicrotic notch. Yes, here you see how ECG causing the contraction causes the change in pressure and volume, the time difference between them. The percentage distribution of blood to different organs. Let us move forward. Here you see more clearly the relationship between systolic and diastolic pulse pressure. See, 1/3 of the time in a period is systolic, 2/3 is diastolic. This is the compliance of the arteries. That compliance causes the flow of blood during the diastolic period when the heart is relaxing. When the heart is relaxing, we don't get any pressure from the ventricle, but we get pressure from the arteries to cause the flow. Yeah, I see. The valve is closed. Arteries are getting back to its original shape and giving us pressure for flow. And this is what is happening in the capillaries. You see now here the real work is done. Until then, all the way from the left ventricle to capillaries, blood vessels have only been carriers. Nothing has been changed on the way. Here, exchange is taking place. And this exchange is taking place because of two different forces that you need to remember. One is hydrostatic force, and the other is osmotic force or diffusion, force due to diffusion. What is the difference between osmosis and diffusion? Yeah? Yes, which is osmosis. Water flows from higher concentration of water to lower concentration, osmosis. And diffusion is everything else because of concentration gradient, higher concentration to lower concentration. So look here, the blood comes into the capillary. Here, because of hydrostatic pressure, higher pressure on this side than this side. The numbers are here below. So it flows out because you have higher hydrostatic inside than in the interstitial space. Outside, you have vascular blood, 5 liters, and extravascular, everything else outside the vessel, blood vessels is extravascular. And now extravascular is within the cells, intracellular space, and in between the cells, we have interstitial space. So here we have the capillaries don't get into the cells directly. Capillaries leak out and collect from the interstitial space. And then comes the next phase between interstitial space and the cells. We are looking at exchange between capillaries and interstitial space. Hydrostatic pressure causes all that is possible, the proteins and nutrients and oxygen in the soluble form to the interstitial space. And because of the osmotic gradient, now what gives higher osmotic gradient inside? Here you have high concentration of proteins. So whatever we have waste products like carbon dioxide, higher concentration here, so it will move in. Urea or elements, chemicals, higher concentration will come back here. So there in this figure, I can't see very well. The numbers are, you see, if you look at the arterial end, your blood hydrostatic pressure is 30 compared to this side 15. And interstitial fluid osmotic pressure is 6. And outside you have osmotic pressure there is 28. So the total on this side is, considering these all four, you get 8 outward. And on the venous end, blood pressure and osmotic pressure and these 4 will give you a sum of -7. So 8 millimeter mercury is outward from the capillary, and minus means inward direction, flowing back to the capillary. But look, here it was 8, and here is -7. So it's not really in equilibrium. There will be something left, right? About 10% will remain there. And that is taken care of by the lymphatic vessels. That brings back to the lymphatic nodes, and then from the nodes to vena cava. And that causes a problem for those who have lymph nodes removed due to some surgery like radical mastectomy, where due to breast cancer, the whole breast is removed, including the nodes, lymph nodes. And then it cannot flow back because lymphs are blocked. And then we see accumulation of fluid and cause of edema, which causing other complications. So here is important to understand the pressure, flow, and also it's very important because of the nutrients. People who do not have enough protein, they will have, it's a disease we see in many countries due to malnutrition, that they are swollen because there is no osmotic diffusion is not taking place. There is not enough protein to pull back. So fluid is accumulated in the interstitial space. Now, you see this gentleman, Stokes and Osborne, they came up with different studies that whether the flow is laminar or turbulent. For example, blood flow immediately after outer valve is not laminar, it's turbulent. What causes the turbulence? Well, it depends on the velocity. Fundamentally, in our case, high velocity will give you high number. Here, this is RE, is Reynolds number, which is related to density, viscosity, length, and velocity and viscosity. Density, velocity, length, and viscosity. If you put their units, density, kilogram per cubic millimeter, velocity meter per second, length in meter, viscosity is Pascal second, you will find the units cancel That's why it's called Reynolds number. And if the Reynolds number is above 3000, then it is considered turbulent. Less than 2000 laminar, between 2 and 3 is transitional. Now, high velocity causes turbulence. What causes high velocity? Yeah, here you see. When the cross-sectional area is reduced, velocity increases. This is from the law of continuity. See. Without if we have a blood flow, suddenly we get some blockage, and then area is reduced. Area is reduced means velocity must increase because the equation of continuity must be valid. If the velocity is increased, then Reynolds number, you see, velocity is increased, Reynolds number will increase. So we will reach area of high velocity and a turbulent flow where the flow pattern is not parallel, where it is not a parabolic flow pattern. And then we have problems with the measurement of pressure and velocity and determine the flow velocity. And the resistance to blood flow is also determined by the viscosity, which is a factor of cholesterol, different kinds. There is low density, high density, or triglycerides. These are the values you get when you do a cholesterol test. But you are far from that, far away from doing that kind of tests. But you should know that when people do their cholesterol test, then it's not only one type of test. It is LDL, low density lipoprotein, called the good. Called the bad cholesterol. High density, they call good one, and then triglyceride. So all these three values are required. So once again, this is a nice representation, graphic representation to understand preload and afterload. Preload is how much you get, and that is the amount of blood volume at the end of this diastole, and how much you afterload is how much you are pumping out, and that is related to the resistance. You see this opening. So preload is the initial stretching of the cardiac myocytes, muscle cells, prior to construction. How much it can stretch, and it's related to ventricular filling. More it can stretch, more it can be filled, right? Afterload is the force or load against which heart has to contract to eject the blood. So that is the type. This includes the outer valve nature, how much it can open, if there is any stenosis, narrowing, or if there is any blockage in the outer. And the third, contractility, that is the intrinsic strength of the cardiac muscle independent of preload, but a change in preload will affect the how much it can toibarhet in Swedish. It's a nice word. Hur mycket den kan tojas. Det beror på hur den är tillbyggda. Va? Sen en gummi. Fairly new gummi can tojas mer if you have compared with the new tire of your bike, tube of your bike, with the old one. There is a difference, right? All right. Different types of measurements, non-invasive and invasive. How you measure blood pressure and how you measure blood flow. Non-invasive, the palpatory method, oscillatory method, ultrasonic method, oscillometric method. Invasive is you have to go in with the catheter. and blood flow, ultrasound Doppler, Lucid Doppler, strain gauge, plethysmography, volume change, electrical impedance plethysmography, again, the change of volume due to more blood or less blood will give you a change in the impedance, and then you get a change in the voltage. Photoelectric plethysmography, thermal convection, and then there are other methods, dye dilution, thermal dilution, and radioisotopes. We'll get back to that. Yeah, this is the you will do in the lab. You will block the artery and see, and then deflate the cuff to see when the first sound is heard, and then the sound disappears. That will give you an understanding about the systolic and diastolic pressure. So you block first. So you inflate the cuff to block the flow, but arterial flow, and then you gradually deflate. See when the sound appears, that's the systolic, and then when it totally disappears, which is the diastolic. And this is the lab we do related to that. We use a piezoelectric sensor. I've described that earlier. So the sensor is compressed because of the arterial wall, charging different amount of charge, causing different amount of charges, and the charges are amplified by charge amplifier, signal is amplified and then filtered, further amplified and filtered again. Here you see the flow is reduced because of the reduction in the cross-sectional area due to plaque formation. And this very often happens in the coronary vessels where the vessels get blocked. Coronary blood supply is very different from other arteries because here you don't get the blood flow during the systole. You get the blood flow during the diastole. Because during the systole, remember, the systole means the ventricle is contracting. When the ventricle is contracting, these vessels are also tensed. They cannot receive blood. So they receive blood during the period when heart is relaxing, during the diastole. And often there is a block and heart tries very much. If there is a block here, new vessels are created around and bypasses to supply blood to the regions affected. It keeps on trying until it cannot anymore, and then you get problems. And then you need to do intervention. Like here you see, there is a test called angioplasty, where a catheter is placed into the, go into with a catheter and see what is the state of the art. I think I have better pictures here. You see, you insert a catheter and see how much is blocked. And if you can clean it, or you need to have a balloon to inflate the balloon and keep it to have it inflated. This device is called stent, a stainless product, stainless steel. And sometimes it's treated with drugs, which stays there and helps prevent further building of plaques. And this is very common these days. People have multiple types of, many have a stent, 4 or 5 of them. in different regions of the coronary vessels. Here is an interesting example of oh, can I just take this one before we finish? Yeah? This is called TIA. TIA is transient ischemic attack. So I'm lecturing and suddenly I can fall down. But then after about 30 seconds, I will wake up. It happens because it's a nice example which combines the two equations we mentioned about, the equation of continuity and Bernoulli's equation. These two equations can explain this phenomena very clearly. Let's say, I mean, it's about 30 seconds we can have our brain without blood. And brain is, compared to any other organs, any other organ can receive more blood or less blood, more fluid, less fluid. It is more flexible. It can change its volume. But brain is covered with cranium, and there is not much room for variations. So if you have more blood flow, then equal amount of fluid must be out. Or if you have higher amount of arterial flow, you must have equal amount of venous return. It cannot manage much variation. Then you get this demonstration of headache and other problems. So for some reason, let's say here, this gentleman, or I don't know, maybe a lady, has a blockage here, right? A blockage here means reduction in the artery, increase in the velocity, which means decrease in the pressure. Here you see, a reduction in the artery will give increase in the velocity. Increase in the velocity will reduce the pressure. So what happens is blood flows to the brain through the subclavian and vertebral artery. It should go to bacillary artery to the brain. But when it comes here, it finds an area of lower blood pressure. Of course, it flows from higher to lower. This pressure is much lower than pressure in the brain. So blood will come back here. And then brain, more than 3 seconds having no blood, will drop. And then if you drop, then as you drop, the pressure here is reduced and blood goes to the brain. And then you wake up. That happens in many cases because of this little blockage here. Right side, one side is okay, but a blockage on the other side can affect the whole brain. We continue with this on Thursday. And on Thursday, in between, you will get, later today, you will get the questions on Canvas. And you can go through them. And if you have any doubts or any unclarity, please take it on Thursday. And then you will have a deadline about 10 days to work with it. Next week, we have no lecture, so you can work next week with that, and a week after. So you do a good job. Take it as a process of learning. And then this will help you to cover the course exam. Any question? Any questions from those who are at home? Hello?
No, it's good.
Okay, thank you. And then I hope to see you on Thursday, right? Same time, 8 to 10.
See you.
Okay, bye-bye.